So the first talk that we have today is by Becky Gould, and she's from UCL, and she's going to be talking to us about the use of ACT in motor neuron disease. I don't know, Becky, if you'd like to join us now.
Hi, everybody.
Hi.
Thanks, Anne-Marie.
You're welcome.
All right, so I'm going to be talking about, as Anne-Marie is saying, my name is Becky Gould. I'm an associate professor in the Division of Psychiatry at UCL, and I'm going to be talking about acceptance and commitment therapy for people with motor neuron disease today. So I'm going to be discussing a number of things, so including a brief kind of sort of recap on what ACT is. So I know that you've there have been previous talks to this, and that you've been discussing kind of sort of ACT concepts, but this is just in case there are people who are kind of sort of new. So we're just going to have a very brief recap on what ACT is, and I'm going to give a brief overview of what MND is as well, for those people who might be joining for the other talk. And then I'm going to be talking about how we adapted ACT for people with MND within the COMMEND trial. Okay, so before we start, I just wanted to do a quick poll. So Anne-Marie, you're in charge of the poll. So the first kind of question was, how familiar are you with MND? So Anne-Marie, you'll have to kind of sort of talk me through. I'm not sure if I kind of sort of see the poll results.
So the poll results, Becky, are just coming in now.
Lovely.
People are quickly answering. I'll wait until we've got a good number.
Okay. So how familiar are you? Not at all, slightly, moderately, very, or extremely. So just help for me to kind of sort of know.
Yeah. Okay, we're up to about 70% now, so I'll just give it a few more moments. Okay, I'm going to end the poll now for you and launch it, so it should.
Okay, so great. So we've got so the majority of people. So in terms of how familiar are you with MND, we've got 35%. So people that are moderately familiar, that's the most common one. In terms of how familiar are you with ACT, again, moderately. So 50% of people moderately familiar with ACT. The 9% and the 15% who are very and extremely, please do feel free to kind of sort of add comments. You know, it's great to have lots of people with experience and familiarity with ACT on the call, on the webinar. And then, how confident do you feel about using ACT? Again, the most common response is 41% moderately. So great, that's really helpful to kind of sort of know. Okay. In true kind of sort of experiential sense, I thought it'd be nice if we can have just a you know, 5 minutes for a kind of sort of time to pause and reflect on kind of sort of what's brought you here today. So so this is going to be strange, kind of sort of doing an experiential exercise when you can't actually see anybody. But what I'd like you to do is just inviting you to close your eyes if that feels okay, or adopting a soft gaze a few feet in front of you on the floor. I'm just inviting you to bring your awareness to the contact between your feet and the floor, your thighs, your buttocks and the chair. Your clothes and your skin. And just becoming aware of whatever sensations are around right now. And now moving your awareness to the breath. And as best you can, noticing all of the sensations as you breathe in. And as you breathe out. And if you notice your mind wandering as minds naturally do, perhaps thinking about what's going to be discussed in these webinars, perhaps thinking about what you've got to do later on today, as best you can, just seeing if you can view the mind as if it's a radio chattering away in the background. So not trying to turn the radio off or change the channel, simply allowing the mind to chatter away in the background. And now inviting you to take a moment to reflect on what's brought you here today. There's something important that's brought you here, something that matters to you. Seeing if you can notice what that is. And becoming aware of any thoughts and feelings that come with this. As best as you can, seeing if you can allow these thoughts and feelings to be just as they are, not trying to change them, not trying to push them away, just allowing them to be. And as we come to the last few moments of this short exercise, just returning the focus of your attention to the breath. And when you're ready, coming back into the room and opening your eyes. Okay. So at this point, we'd be usually doing an inquiry to kind of sort of ask about what you notice coming up for you. But of course, for this kind of webinar, it's a bit more difficult. But just kind of sort of reflecting on what came up for you in that exercise. Okay. So turning now to kind of sort of recapping on what ACT is. So as you know, ACT is a third wave acceptance-based behavioural approach, and it focuses on changing our relationship to our thoughts and our feelings, rather than trying to change the content or the frequency of our thoughts and our feelings. And it's a therapeutic approach that uses acceptance and mindfulness-based processes, as well as kind of sort of behavioural and commitment so change processes, in order to be able to help increase psychological flexibility. So in ACT, the hypothesis is that psychological inflexibility is the psychopathology that kind of sort of, it underlies the psychopathology, and it's the psychological suffering that emerges from all of these different processes that are highlighted in red. And so the aim of ACT is to try and increase psychological flexibility by targeting each of the processes highlighted in blue. So kind of sort of, when we think about psychological flexibility, you know, there's so many different definitions of it, and people use different things. But certainly, I think the one I kind of like is about it's someone's ability to be able to choose with awareness how to flexibly respond to their internal experiences, their thoughts, images, memories, emotions, sensations, in order to do the things that are important and that matter to them. And it's hypothesized that ACT increases psychological flexibility through these 6 core processes in blue. So I'm just going to go very quickly, just go through those for the people who are kind of sort of less familiar. So acceptance, or what a lot of people prefer to call willingness, is about accepting, opening up, or making space for difficult or unwanted internal experiences when those are barriers to life-enriching activities. And that's rather than trying to change, avoid, or get rid of them. Cognitive diffusion is about stepping back or unhooking yourself from unhelpful thoughts, so and images and memories. So being able to see your thoughts just as thoughts, rather than kind of getting hooked by them, rather than buying into them, or rather than treating them as if they're the literal reality. Contact with the present moment is about being in the here and now, rather than being stuck in your head, ruminating about the past or worrying about the future. Self as context, the notoriously tricky process within the hexaflex, is about seeing yourself as distinct from your internal experiences. So being able to see yourself as distinct from your thoughts, images, memories, emotions, sensations, rather than seeing yourself as being defined by them. And another way of viewing that is about being able to hold the stories that we tell about ourselves and the world, being able to hold those stories lightly rather than being caught up in or attached to them. Values is about knowing what really matters to you, so what you want to be doing, crucially how you want to be doing that, and the type of person that you want to be, rather than kind of losing connection with that. And committed action is about committing to doing the things that really matter to you, rather than engaging, rather than doing nothing or acting on impulse, or persisting in kind of sort of avoidant behaviours when those aren't working. An easier way to conceptualise the hexaflex is Russ Harris's triflex, in which psychological flexibility is conceptualised as opening up, as being present or being aware, and being engaged. And so it's really a nice little model to think about too. In terms of the goals of ACT, so there are 3 main goals. So essentially the aims of ACT are to help people to be more open to and accepting of their experiences, rather than engaging in ineffective or futile struggles with them. Another aim is to help people to become more aware of their experiences in the here and now, so rather than being stuck in their head ruminating about the past or worrying about the future, and rather than not being able to see themselves as distinct from their experiences, so rather than being defined by their experiences. And then a further aim is to help people to commit to doing things guided by what really matters to them, rather than what they want to avoid. And the important thing about ACT, it's not aimed at symptomatic reduction, although that can happen as a byproduct of therapy. So instead, it's aimed at increasing somebody's willingness to experience unwanted internal experiences, in order to do the things they can that are important, that matter to them, be the type of person they want to be. And that's the kind of sort of the really crucial thing. So we're not asking people to kind of sort of wallow, wade into the kind of sort of the swamp of misery and wallow in it just because they can. We're asking them to make contact, to make space for all these difficult thoughts, feelings, sensations, etc., in order that they can get to the other side, in order that they can do the stuff that's important and that matters to them, be who they want to be. And ACT, as you know, uses a variety of different experiential exercises and metaphors as a vehicle to help increase psychological flexibility and to help increase people's willingness to experience unwanted thoughts, feelings, sensations, etc. Okay. And I just wanted to make a few kind of sort of points. So the first is that not all forms of experiential avoidance are unhealthy. So it's important to remember that, you know, we all engage in experiential avoidance, and certainly many forms of experiential avoidance are kind of adaptive, and others might make little difference to long-term quality, life quality. So, for example, the couple of a glass of wine that might be having tonight, in order to be able to help relieve the pressures of the day, that's certainly not going to have any major impact in the long term. So the key thing about ACT is it only targets the experiential avoidance that is serving as a barrier to life-enriching activities, that's getting in the way of people doing the things they want to do or being the type of person they want to be. Another key point is that function is more important than form or frequency. So many behaviours kind of have different forms, but they have the same function. So, for example, drinking alcohol, avoiding going out, engaging in distracting activities, they all have different forms, but they have the same function. For example, experiential avoidance. And if you target form rather than function, then all you get is another behaviour popping up in the same functional class. So therefore, if you target the function of the behaviour, then you're going to be more likely to see behavioural change. So the function of the behaviour is more important than what something looks like or how often it occurs. And then finally, truth is defined on the basis of workability. So we don't need to get in discussions about the evidence for and against thoughts, or whether something's right or wrong. It's simply about whether a thought, for example, is working for that person, whether it's helping them to move towards the stuff that is important and that matters to them being who they want to be. Okay. So turning to MND now, in terms of what MND is, so MND is an umbrella term given to a group of related diseases that affect the motor neurons in the brain and the spinal cord and result in loss of ability to be able to move, speak, swallow and breathe. There are 4 main variants of MND. As we see got listed here, with ALS being the most common variant. So about 60 to 70% of cases have ALS. And there the different variants of MND are characterised by different patterns of degeneration of the upper and the lower motor neurons. MND is an uncommon condition. It affects about 5,000 adults at any one time in the UK, and it mainly affects people in their 60s and their 70s, although it can affect people, adults of other ages. In terms of the signs and symptoms of MND, so the symptoms really depend on the type of motor neurons that are affected. So if there's degeneration in the upper motor neurons, a person might experience symptoms such as emotional lability, the weakness, the increased muscle tone, and brisk kind of sort of over-response reflexes. If there is degeneration in the lower motor neurons, people might also experience weakness. They might experience things like called fasciculations, which is muscle twitching or kind of sort of rippling. So you kind of sort of see this kind of sort of rippling motion in the muscles. They might also experience cramps, decreased muscle tone and muscle wasting, and kind of sort of depressed reflexes. There's also so increasing recognition that, you know, approximately 35% of people with MND without dementia experience mild cognitive and behavioural changes, and these tend to be of a dysexecutive nature. So approximately 15% show signs of frontotemporal dementia. So I'm not going to be focusing on the kind of sort of frontotemporal dementia aspects today. It's very much more people with MND who without dementia. And in terms of prognosis, when most people think about MND, they think about somebody like Stephen Hawking, who was diagnosed with MND when he was 21 and survived for 55 years. Unfortunately, that's the exception rather than the rule. And median survival is around kind of sort of 2 to 3 years following symptom onset. But different rates of progression are seen with the different variants of MND. So progressive bulbar palsy is the most aggressive, so people might only survive 6 months following symptom onset, whereas primary lateral sclerosis is the slowest, and people might survive 10, 20 years. There's no cure for MND, and the current disease-modifying drug riluzole has a kind of limited effect in terms of survival. I think one of the challenging things in MND is the fact there's a lot of variability. So there's variability in terms of symptom onset. So different parts of the body can be affected first in people, and then there's variability in terms of the pattern of spread. So, which parts of the body are affected next and in what order. And there's variability in terms of the speed of the disease progression, as we've already mentioned. And what that means is that variability means it's kind of difficult to predict the life course, the disease course, and therefore people can experience quite a lot of uncertainty. In terms of mood disorders in people with MND, so the prevalence rate's around 44% for depression and 30% for anxiety, but those rates can vary depending on the assessment tool used. So depending on how much overlap there is between the mood questionnaire, for example, and symptoms of MND. So for example, there is some overlap between symptoms on the HADS. There's evidence that people are most kind of sort of vulnerable, most susceptible to depression in the year after diagnosis, and particularly if the rate of disease progression is more aggressive. So, for example, in things like progressive bulbar palsy. And there's also evidence that psychological distress is associated with a range of negative outcomes, and this is including things like shorter survival times, which might be because people are refusing life-prolonging interventions such as non-invasive ventilation or gastrostomy. We know that psychological distress is associated with a poorer quality of life, an increased risk of suicide, and an increased risk of mortality. So there are a lot of reasons why we should try and address psychological distress in people with MND. And unfortunately, at the moment, there aren't any recommendations about how we can address psychological distress in people with MND. So the MND NICE guidelines were published, the revised version were published in 2016. And the main recommendations with respect to kind of sort of psychological aspects are that the multidisciplinary team should kind of sort of discuss the psychological and emotional impact of MND and discuss people's psychological or support needs, and then people should be signposted to psychological therapy where necessary. They weren't able to make recommendations about what psychological therapy people should be kind of sort of referred for, because there's not enough evidence at the moment to recommend anything. So there wasn't enough evidence at that time, and there still isn't, and that's where the COMMEND trial comes in. So the COMMEND trial is a 4.5-year study funded by the HTA and the MND Association, and we've got a number of co-applicants, if I can say that word, across the UK, so including Chris Graham, who was on one of the webinars, I think it was it last week or a couple of weeks ago, and also including Lance McCracken, who's expert in ACT for chronic pain, and Mark Sveti, who's expert in ACT for advanced cancer. And we also have Chris McDermott, who's a neurologist at Sheffield, who's co-leading the RCT with me. So the HTA issued a commissioned call for a brief psychological intervention for people with MND for improving psychological health, and so we chose ACT which is why I'm talking about that today. And there are a number of reasons why we chose ACT as a psychological intervention for people with MND. So first of all, a number of people have argued that ACT might better meet the needs of people with conditions such as MND. It's not possible to cure MND, so helping people to adopt a focus on what's possible and how they can best live their life, rather than trying to kind of sort of control or get rid of distressing experiences, might be kind of a more pragmatic approach. Another reason why we chose ACT is that the evidence from systematic reviews is that ACT can improve functioning, quality of life and mood in a range of chronic diseases and life-limiting illnesses. A third reason that we've chosen ACT is that techniques used in kind of more conventional CBT, such as thought challenging or problem solving, they might not be as kind of sort of effective, or they might not be as acceptable to kind of people who are experiencing multiple losses, a stark prognosis and kind of sort of unsolvable problems. And then another reason is that there's evidence that psychological flexibility predicts quality of life and adjustment in MND and other kind of sort of progressive or incurable conditions such as muscle disorders and advanced cancer. And finally, there's evidence that from Francesco Pagnini that meditation training is beneficial for people with MND. So they did an RCT of meditation training and found that it improved quality of life, and therefore ACT, with its kind of sort of focus on commitment and behavioural change processes, might be even more kind of sort of beneficial for people with MND. So the main aims of the Commend study are to develop a manualised intervention based on ACT for people with MND, to examine how acceptable and feasible that is, and then to determine how kind of sort of clinically and cost effective it is in comparison to usual multidisciplinary care. And the main thing I'm going to be discussing today is how we actually developed and refined our intervention for people with MND. So we took a two-stage approach to the development of the intervention. So we started off by conducting a series of qualitative interviews with people with MND and caregivers and healthcare professionals. And then we refined the, we used those results to kind of sort of develop an intervention. We then refined the intervention. So after people had experienced it within an uncontrolled feasibility study. So as mentioned, we started by conducting a series of qualitative interviews with people with MND and caregivers and healthcare professionals. And in these particular interviews, we were interested in exploring what kind of things might help or hinder engagement in psychological therapy, how we might adapt ACT for people with MND, and kind of sort of some of the issues that therapists might need to be aware of when delivering ACT. We identified a number of themes and sub-themes, so these are illustrated here. And I'm not going to go into all of these kind of sort of themes and sub-themes now, because I'm going to kind of sort of save that for when we're talking about how we adapted, how we developed our intervention for people with MND. But suffice to say, we use these themes and sub-themes to kind of sort of make a series of recommendations about what psychological interventions for people with MND should look like. And so there's more information about that in the paper by Kirsty Weeks. We then conducted an uncontrolled feasibility study in order to test out the acceptability and the feasibility of our intervention. And we also conducted the qualitative interviews of people with MND and therapists, and we used, in those interviews, we explored people's experience of receiving ACT and therapists' experience of delivering ACT, and we were also interested in seeing, what kind of changes we might need to make to the intervention in order to kind of sort of take it through to a randomised controlled trial. And again, we identified a number of different themes and sub-themes themes, and I'm going to be talking about these as we're going along. So in terms of the adaptations that we made, so we made a number of different adaptations. So first of all, in terms of thinking about ACT processes, one of the things that we did was we encouraged therapists to focus on values in earlier sessions. So we know that MND more typically presents in those people aged in their 60s and their 70s, and it's been suggested by people like Julie Weatherall, who's done a lot of work in things like ACT for older people and CBT for older people, lots of work with older people, but it's been suggested that adapting ACT so there's an early focus on values can improve outcomes in older people, as well as kind of sort of increasing the likelihood that people actually engage in the therapy. We also, in terms of focus on contact with the present moment, we also included a centering exercise at the start of each session. So kind of sort of similar to the exercise that we started with at the beginning of our session. And the reason we did that was that, again, some of the work of ACT for older people found that sometimes older people can experience difficulties in recognizing or describing, observing or being aware of their internal states. And so we wanted to be able to kind of sort of include that centering exercise to really kind of sort of help bring that focus. And the other reason that we wanted to ensure there was a mindfulness exercise explicitly in each session was because Francesco Paganini, in his meditation training RCT, kind of sort of suggested that actually helping people to sit with whatever arises in each moment without trying to change it, without trying to push it away, might be particularly beneficial as people become more physically immobile, and particularly as people advance to more kind of sort of potentially locked in states. We encourage therapists to focus on fusion and self as content, and introduce perspective taking throughout our experiential exercises. So one of the things that we tried to do is kind of having a drip approach with respect to kind of sort of self as content, and we did that in experiential exercises by helping people to kind of sort of notice what thoughts, feelings, sensations are showing up, and seeing if, and then including instructions about noticing, seeing if you can notice the part of you that's noticing the thoughts, feelings, sensations, seeing if you can notice that the you who notices those thoughts, feelings and sensations is separate from them. So we kind of sort of tried to bring that in where possible. And again, the reason for that is that you know, people can kind of sort of be fused with a kind of sense of them, a conceptualized sense of themselves as being disabled or having a terminal illness. And again, Francesco Paganini in his work kind of discussed the importance of being able to help people to adopt a more flexible perspective in order to help kind of prevent the embodiment of those kind of sort of labels. In terms of the choice of metaphors and exercises, so we very carefully, we gave a lot of thought to the kind of metaphors and exercises that we should use. So we avoided certain exercises such as the tombstone exercise or the eulogy exercise for obvious reasons. And then based on kind of our PPI feedback, we avoided metaphors such as the swamp metaphor, because some people kind of sort of said that actually, do you know what, living with MND feels like walking through a swamp, so those kind of sort of physical immobility issues. So we didn't want to kind of sort of cause additional distress, and so based on PPI feedback, we didn't focus on those. And what we did ensure is that we included a range of metaphors and exercises that therapists could adapt their delivery of ACT depending on the person's unique physical, communication and cognitive needs. And then we also what is known as selection, optimization, and compensation principles in committed action kind of sort of exercises. So these kind of principles, they originally developed by Boltus et al. To aid adaptation to kind of sort of the challenges of aging, so kind of helping to facilitate successful aging. And they've been applied to things like ACT for chronic pain, and they essentially involve strategies for helping people to choose the best goals to focus their resources on, to optimize how they can engage in their goals, and to kind of sort of compensate for any particular losses or difficulties they might be experiencing. So just to go into this in a little bit more detail. So some of these selection strategies might be about selecting or limiting goals to the ones that are most in line with someone's most important values, or that are in their best domains of functioning. It might be about adapting goals or focusing on specific aspects to make them kind of more realistically achievable, or it might be about replacing goals, so the goals that people can't achieve anymore, identifying what it is about those goals that's important, and finding other ways of being able to kind of sort of tap into those underlying values. Optimization strategies might be practicing or learning new skills, and compensation strategies might be about asking people for help or using these kind of sort of aids and adaptations to compensate for losses. So an example relevant for kind of sort of people with MND might be a professional artist who can no longer paint due to physical immobility. So an example of select strategy would be selecting the goals and the values that kind of sort of most important. So it might be about acting with creativity and then adapting the goals so that they can be more realistically achieved. So if somebody can't paint with their hands, seeing if they can paint via other means, for example, by using eye movements. Optimization strategies, so it might be, say for example, if someone is going to create digital artwork using eye movement, then it might be about learning how to use this kind of new software, and compensation strategies about using those particular types of software and assistive technology such as eye tracking technology in order to be able to create digital artwork. And an example of that is, for example, Sarah Ezekiel, who is, so she's a professional artist. She was diagnosed with MND in 2000, and she creates digital artwork using eye movements. Some fantastic work she's created, and so I definitely recommend looking at her website if you get the chance. In terms of how we adapted ACT for people with MND in terms of therapeutic delivery, I think one of the big things that came out of the qualitative interviews was about the real need for flexibility. So flexibility in terms of geographical location. So we made sure that the therapy could be delivered in clinic, at home, or remotely via video conferencing. There needs to be flexibility in terms of the pace of the session, so being able to kind of sort of go slower if people are using assistive communication devices. And we need to be able to be flexible in the content of the session. So, for example, flexibility in which metaphors and exercises to use depending on someone's cognitive, physical, and communication needs. We also adapted some of the terminology we use, again following our qualitative interviews. So for example, using the term willingness rather than acceptance, because some people reported negative connotations with acceptance about giving in or giving up. We also emphasised the use of the willingness question. Would you be willing to give this a go? Would you be willing to answer this? Would you be willing, whatever? And the reason we wanted to include that was because obviously it's good practice to be doing that, but also it's been suggested in previous research that people with MND kind of sort of strongly value control over their healthcare decisions, because they might be kind of sort of losing control in so many other different areas in terms of the losses that they're experiencing. So this might be one area that can help to kind of sort of empower people. And then we also made sure that there was space to discuss the end of life or existential issues in an ACT consistent way if people needed to do that. Because again, there's evidence showing that that's kind of sort of really beneficial to be able to kind of sort of help normalise those kind of sort of conversations, but then also kind of sort of to help kind of sort of help people to maintain support networks and things like that. In terms of involvement of caregivers, we invited caregivers to be involved in the first session and the sessions on committed action. So we wanted everybody to be on the kind of sort of same page in terms of the first session, because obviously if you've got kind of sort of the caregiver might be expecting that someone's distress might be reduced as a result of the sessions, and of course that's not the main aim of ACT. It's not aimed at symptomatic reduction, it's about helping people to live as best a life they can with kind of sort of, in this context, MND. And we also involve people in the committed action sessions because obviously it helped with things like the goal planning. In terms of communication difficulties, so one of the things that we did was we invited a speech and language therapist called Richard Cave, who's at the Royal Hospital for Neurodisability. We invited him to join the training of therapists, and he gave therapists kind of sort of general recommendations about communicating with people with MND. For example, you know, things about kind of maintaining eye contact with the person and not the communication device, and checking preferences about you know, things like finishing sentences or the seating position. Again, as I mentioned, we ensured that sessions were flexible so that actually, you know, people could go slower if necessary. And we also replaced, we made sure that the verbal exercises and metaphors people could use actually the more kind of sort of written exercises, for example, or we use ones that people could imagine. So for example, instead of milk, 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 we encourage people to use the I notice I'm having the thought exercise, because you can do that without overt speech production. In terms of how we adapted ACT for people with physical difficulties, we made a number of adaptations in terms of mobility, breathing, swallowing, and fatigue. And these, a lot of these were around things like more mindfulness elements. So in terms of helping people to bring mindfulness into their daily lives or contact with the present moment, rather than, say, for example, mindfulness walking, if people couldn't do that, we brought in mindfulness of minimal movement. So for example, tracking the outline of a circle with one's eyes. We again replaced things like written exercises for more verbal exercises, or just imagined kind of sort of completing those. And we kind of sort of adapted how we handled various different physical props, for example, in the labels exercise where you have luggage labels. In terms of breathing, I think the main adaptation that we made there was about providing an alternative to focusing on the breath. And the reason for that is obviously the breath can be quite scary for people with MND, particularly if they're experiencing difficulties with their breath. So we gave people a focus on the sensations of the feet on the floor or their footrests, the sensations of their hands on their lap or on their armrests, and the clothes in contact with the skin. And because we wanted to kind of sort of people to continue using these kind of exercises as the disease progresses. And obviously, if we had too much focus on the breath, then we were concerned that people might kind of sort of, when it gets to that point, kind of think, nope, don't want to do this. So we gave that alternative focus. Things like kind of sort of swallowing. So again, bringing in kind of sort of those more mindfulness elements, that if, you know, people do have swallowing difficulties, it's about focusing on things like mindful listening and mindful smelling. And then we made kind of adaptations in terms of fatigue. So, you know, allowing people to have rest breaks, allowing, you know, breaks to reposition themselves in their chair and all those kind of things. And then in terms of adapting ACT for cognitive and behavioural difficulties, so we didn't include people with frontotemporal dementia in the study because delivering ACT to people with frontotemporal dementia is a kind of whole different ball game. So we didn't adapt ACT for the kind of more moderate changes. So this is more considering the mild cognitive behavioural changes. So we made therapists aware of some of the potential cognitive changes, things like some of the difficulties with category switching that people might experience and perseveration. So, you know, in some of the exercises, if you're asking people to switch between, you know, imagine the words on the computer, on a monitor, imagine it in this colour, now imagine it in this size. So obviously raised awareness that people might have difficulty with that switching. And we also emphasised the need for things like using the concrete metaphors and experiential exercises. So avoiding the more abstract metaphors such as the chessboard exercise, which we really weren't recommending, you know, because it's so abstract, and experiential exercise a bit more abstract, like the physicalizing exercise. So we kind of sort of encourage therapists to use the more concrete metaphors and things that are more visual, things that might use more physical props. And then we kind of raised awareness of the behavioural changes as well. So, for example, some apathy, where, you know, the awareness that people might need prompts in terms of they might not be able to kind of sort of self-initiate using some of these new ways of responding to the internal experiences. And we also discussed the importance of emotional ability and just being aware that kind of sort of displays of emotion, for example, there might be kind of more reflective emotional ability, as opposed to, you know, the fact that you've touched on something difficult in the session. So we kind of highlighted the importance of kind of sort of, you know, raising questions about that. So in terms of the session outlines, so we offered participants up to 8 sessions, and each session was associated with a particular set of metaphors, exercises, and kind of sort of home practice tasks. Session 1 was the assessment session, where we really introduced ACT, and then session 8 was the kind of more review session. Sessions 2 to 7, therapists were able to choose the order in which they delivered those sessions. So there was a main focus of the sessions, so say for example values, but then therapists were encouraged to what we call dance around the hexaflex, so to bring in all of those different ACT processes in the kind of sort of the questions that they were asking. And as I mentioned, we brought in a centering exercise in each session, and we also brought in a committed action kind of sort of small exercise in each session, so asking people to identify the smallest step they could take to move them towards the things that are important and matter to them, being who they want to be. And essentially the sessions are broadly aimed at exploring kind of sort of what a person wants to do, and crucially how they want to be doing it, and the type of person they want to be when they're doing it. We explored the thoughts, images, memories, emotions, sensations that were getting in the way of those things, and then what they do when those particular internal experiences show up, and just how well those ways of responding were working for the person, how well if they're working in the short term and the long term in terms of helping them to move towards what's important, what matters. And then we explored kind of sort of new ways of responding to their internal experiences. And we used, as I said, a number of different metaphors and exercises to be able to help people explore these new ways of responding to their internal experiences. Okay, and we're currently evaluating the clinical and the cost effectiveness of our ACT intervention for improving quality of life in people with MND. So the COMMEND trial is ongoing as we speak. And on that note, so if you would happen to like to be involved in the Commend trial, we've got numerous sites across the UK. We're always looking for therapists who are interested in being involved. It's a 4.5-year study, and people do move on. So we're always really keen to bring on kind of sort of new therapists. We can offer free training and supervision, and can negotiate things like excess treatment costs with NHS trusts. The Commend trial, I just have to say, is so important for us. One of the things we know when we're applying for the grant is that a lot of M&D clinics don't have kind of sort of regular access to psychology. They don't have regular access to psychological therapy. That is starting to change now, but often kind of sort of when we kind of sort of discuss it with M&D clinics, they've kind of sort of said that commissioners have argued that there's no evidence, there isn't good evidence for psychological therapy in people with M&D. This could hopefully will provide that evidence to kind of sort of help support that argument for having psychologists routinely embedded in M&D clinics. So yeah, if you want to get help, if you can help, we would massively appreciate that. Okay, so in summary, we've discussed a number of reasons why ACT might be particularly suitable for people with MND, and we've considered the various different issues and adaptations that might need to be made when delivering ACT. Some final thoughts. If you haven't read Tuesdays with Maury, then I highly recommend it. It's a great book. It's based on conversations between Maury Schwartz, who's a sociology professor, who had ALS, and a former student of his, Mitch Albom, and it kind of sort of documents their conversations over a series of Tuesdays, and there are all sorts of just kind of amazing quotes that are in there that are very kind of sort of ACT consistent, and just a few of those are listed here. So in terms of some acknowledgements then, just need to thank all of our participants in the Commend trial, and a huge massive thank you to our study therapists and our supervisors, our PPI representatives, and so on. And it's just to acknowledge the funding by the HTA as well. Fabulous. So whistle-stop tour around ACT for MND, and I guess now we can go for questions. So let me just stop sharing.
Hi Becky, thank you very much for an excellent talk. That was really interesting. And as you know, I was one of the treating therapists in the early stage, and I would highly recommend it to anyone. The quality of the training that you get and the supervision is brilliant, and it's changed my practice working with people with MND. So I really would recommend it.
Oh, thank you. And we miss you, Anne-Marie, so much.
Oh, it was great. I really enjoyed it. Now, I can't see any questions. I wonder if there's a problem with my question function. I don't know, Becky, if you can click on the questions and see. At the bottom of the screen, there's a Q&A section. I don't know why it's not working for me.
No, there are no questions.
Well, I've got some, so if other people do have questions, then please do put them into the question and answer section at the bottom, and I'll keep checking. But I guess, Becky, I was just thinking, you mentioned that the centering exercises are really important when working with people with MND. Can you recommend any centering exercises for people to use?
Yeah, so I mean, very much kind of sort of the exercise that we did at the beginning of the session. So I think it's always really helpful to kind of sort of just to help bring people's awareness to whatever thoughts, feelings, sensations around, but then kind of sort of, I think, tapping into kind of sort of what's brought them to the session, and then and kind of sort of what underlies that, so the kind of sort of the values, you know, there's something important in that to them. I think, you know, if you're bringing in those kind of things, that's really helpful. I mean, and then obviously the very brief exercises that Russ Harris has, you know, the notice 5 things, those kind of things can be kind of helpful. There's also things like a very brief self as observer exercise, kind of sort of, so noticing thoughts, feelings, sensations, and then noticing the part of you that's noticing your thoughts and feelings, etc. But you know, those kind of things are all really helpful.
Great, that's really helpful. Now I can see a few questions popping up. Um, so Fiona's saying, hi, I wondered if it would be useful, given what you say regarding psychology move towards training core rehab, people to do ACT within their own offers too, a hub and spoke model. Any thoughts on that, Becky?
Training core rehab to within their own offers?
Yeah, I guess.
I don't know what that means.
I wonder if that means, not sure actually.
I think kind of sort of ACT for core rehab people. So, so if that means in terms of kind of things like the multidisciplinary team,
Yeah.
then I mean, one of the things I'm really keen on is this kind of sort of notion about being able to pass on kind of sort of these ACT principles to kind of sort of other team members. So Lance McCracken has done a great study where he looked at physiotherapy informed ACT, and so it wasn't the physiotherapists were delivering ACT, but they were just doing physiotherapy within an ACT consistent approach. And I think kind of sort of having people move towards that approach is fab.
Yeah, and I think lots of other MDT members are often very focused on values, but just might not have the conversation in the same way that we would. So that's a helpful thought. Somebody else is also saying that they are setting up an ACT group therapy intervention for long-term conditions, and they're wondering if you've got any quick tips you can give for delivering to a whole range of people at once. I guess that's quite different, isn't it, to individual therapy?
Yeah, definitely. I think, I mean, I think kind of sort of then what it might be is that, you know, if you are kind of sort of using particular experiential exercises within the particular group, it might be about just ensuring there's a balance of more kind of sort of verbal, you know, more verbal ones and more kind of sort of physical ones, so that actually everybody can kind of sort of engage. I mean, I always think that it's actually really good to be able to have a mixture of those things as it is anyway, because, you know, we all have our own preferences about, you know, we might not like this type of exercise, but we, you know, we don't like this particular exercise. So if we can bring in that variety as much as possible, then I definitely kind of sort of been trying to do that.
Yeah, and people can learn from each other's reflections, and that can be really helpful too. I'm just aware of the time, so I think we've probably got time for one more question. Let me just have a quick look. So somebody here has asked, how do you control for the additional time and input that ACT therapy is providing for patients over and above their normal MDT input in determining outcomes?
Yeah, we're not. We're not. It's one of those massive, so the HDA, the NIHR HDA, they have this preference. They want you to do, rather than the kind of the scientifically pure kind of research, they want you to look at what is currently being employed in the NHS right now. And, you know, and they want to sort of see, okay, if you have an intervention that is actually better than what is currently involved in the NHS right now, then they'll get it rolled out, or at least they'll kind of sort of promote the kind of the rollout of that. So it's definitely, we don't have an active control, and we did think about having that, but obviously it was very challenging to do that with kind of people with MND as it is in terms of recruitment. So in an ideal world, yes, we would have a weighting, so we would have a non-active control and an active control, but sadly it's not the real world. It's a pragmatic approach.
Okay, and I'm just going to sneak one more in because I'm interested in the answer myself. So Audrey Glazley says, you mentioned involving families. How does this happen? Most of my work with people with MND involves relational work, as their family members are typically their primary concern. So I'm keen to know, how do you involve families?
Certainly, I think, I mean, all of that has got to be with the permission of the person with MND. Our qualitative interviews with participants really strongly kind of sort of recommended bringing in kind of sort of caregivers. They kind of sort of say that they're often forgotten about, and that if we can incorporate them within the sessions, then that's kind of sort of obviously beneficial. But obviously one of the things you've got to be careful about there, especially things like committed action, is the pliance issue, kind of sort of so making sure that, you know, there isn't pliance. So I think you've definitely got to manage that quite carefully. Can't really kind of sort of, I haven't got enough time to go into it in massive detail.
That's really helpful, Becky. Thank you so much. It's been really interesting. It's nice to see you again.
Yeah. Thank you for inviting me.
You're very welcome, thank you. We're going to take a short break now just for 5 minutes, so if we could come back at 6 minutes past 11 for Will's talk, that would be great. Thank you.
Bye.
Bye. Hi and welcome back. It is 6 minutes past now, so we are going to get started in a moment. Before we start, just to reiterate, if you pop your questions in the Q&A section at the bottom of the screen, then we'll do our best to get to them. Apologies if we don't get to all of them, but I know that Becky is going to try and answer some of them now via the Q&A section. So I'm going to start by introducing Will Curvis, who is a clinical neuropsychologist who's going to talk to us today about ACT in an acute neuropsychology setting. So Will, if you'd like to join us. Hi Will.
Hello.
Welcome. Thank you for coming to talk with us today.
Thank you for having me. It's nice to be here.
Are you all good to screen share and get things started?
Yeah, this might be the where I run into challenges in my technical competence.
Okay.
I think.
It's a learning curve for all of us.
Let's hope this works. So how's that? Can you see that?
Yeah, we can see that. So, well, if you do your talk and then at the end we'll take questions.
Yeah, great. That sounds good. Right, so hi everyone. Thanks for joining. So my name's Will. I'm a clinical psychologist and a clinical tutor. So I work part-time at Salford Royal, which is just near Manchester, in the neuropsychology department, and I work part-time on the Lancaster Clinical Psychology program as well. So hello. I'll be.
Sorry to interrupt. Could you just put your shared screen on the slideshow so it's on rather than we can just see your admin at the minute.
Yeah.
Thank you.
There we go. That's better. Right. Yeah. Thanks for that. Is that okay?
Perfect.
Yeah. Cool. Thanks. Sorry about that. I'm a bit new to Zoom. We usually use Teams, and I'm still getting my head around that. So changing platforms.
I know. Don't worry, everyone's the same.
Yeah, so just wanted to say a bit about what I'll be kind of chatting about today. So the idea of my talk today is to think a bit about the potential role for ACT in what I've called acute neurosurgery settings. So I'll chat a bit about my job at Salford, but hopefully some of that will be applicable to other kind of acute kinds of services as well. I just want to give a bit of a shout out to Abby as well, who can't be with us today, but is quite responsible for contributing to a lot of the content today. Abby and I are working on a book, which I'll tell you about a bit later on. So quite a lot of the ideas that I've kind of tried to work into today are from that. So I just wanted to give a shout out and say hello. Right, I'll get cracking. So just a bit about me. So I, as I mentioned, I work part-time in an acute neurosurgery ward. My background since qualifying has typically been in quite acute services. So my first role after I qualified was between A&E and a major trauma service. So very much at the kind of early stages of different medical pathways. So moving into a neurosurgery context was felt quite natural next step really. So I think what I quite enjoy about that role is working into very kind of sort of medicalized environments where they are very medically dominated, but I think there's real opportunity there for integrating some psychology practice and some psychological thinking. In terms of how I've tried to structure the session today, I was very grateful to Becky in the last talk for giving an overview of some of the theoretical stuff, because that's definitely not my strong point. So I've put some slides in about some of that kind of stuff, but I will gloss over that. So I'm hopefully not repeating too much about what she said. And what I'll try and do is keep the focus just on what I've kind of found useful from working in some of these acute contexts. and hopefully think a bit about how some of those ideas might be kind of adapted into that kind of a world. I just want to say as well, I'm still getting used to the whole remote teaching kind of stuff. I've done bits of it here and there, and it's definitely a challenge for me in the way that I usually teach. You know, I tend to really value things like group discussion, experiential exercises, especially with a topic like this, and obviously that's quite tricky to do today. So what I would ask is just kind of, yeah, if there's things where I'm talking about, just try and link it to your own experience as much as you can. Try and think of examples that you can bring to mind, just as we would if we were all in a room talking to each other. I will try and keep my rambling to a minimum. It's really weird if you've not done anything like this before. It really just feels like you're talking to yourself for an hour or so, which is a very strange experience. So yeah, I will do my best to not ramble, but hopefully there's some opportunities within that as well. You know, I think it does give us opportunity to kind of firstly reach a wider audience, to look back on us again and again, and hopefully be a bit of a resource to prompt some thinking further down the line. The other thing I just wanted to mention before I get started is just about confidentiality and anonymity. So just because of the nature of the folks that I tend to work with in my clinical role, it isn't really appropriate for me to be kind of getting permission to say, you know, can I tell your story in a teaching session? So I tend not to do that. What I tend to do is talk quite vaguely about people in a kind of amalgamated way a lot of the time. So I might be drawing on examples that aren't true but would be typical, if that makes sense. So I hope that the examples that I'll bring to mind as I'm talking will be based on kind of real stuff, but will hopefully be suitably confidential and anonymized. Yeah, I hope that's all right. Okay. That's right. So I guess I wanted to start by just saying my background clinically was in CBT. So before I trained as a psychologist, I worked in IAPT, so improving access to psychological therapies. So I guess I just want to start this by saying, you know, my understanding of ACT and the concepts around it is still very much developing. You know, we had quite a bit of teaching while we were training on this, you know, quite a bit of reading and training since qualifying. But what I really like about ACT is that it very much feels like a developing field. There's always new ideas coming around, there's always new resources around. So I think I would very much kind of own it and say I'm not an expert or a purist in any way, shape or form in terms of ACT. I think what I struggled with in the early stages of learning a bit about ACT was the experiential stuff. I think it took me a bit of time to get used to feeling daft enough to give things a go. I struggled a bit with doing mindfulness exercises in a room full of people, for example. So I just wanted to mention that if you've been put off any of these kinds of things before because of that, then I'm right there with you. You know, I think there's definitely something about just being willing to give it a go and willing to give it a try that's very much generalizable to trying to help people do that for themselves as well in a therapeutic context. And again, if we were in a real room, I'd be encouraging you to do daft exercises to really push that, because that was a big learning point for me. Yeah, I'm also, again, I'm probably not painting myself in a good light here, but I'm not very good at theory. I'm not very good at models. I never have been. I think I'm not an expert or a purist in really any model, certainly not ACT. You know, I think there's a lot of very intelligent, bright people out there who can explain this stuff way more eloquently and thoughtfully than I'll ever be able to do. What I've always tried to do whenever I'm kind of whenever I'm working clinically or whenever I'm teaching is to just try and drill it down into the really simple, understandable stuff, because that's how my brain works. I'm not very clever, so I think being able to bring it down to the core bones of it is how my mind tends to work. So that's what I'm going to try and do today. So please save your critiques of how I'm wrong about this or wrong about that for someone else. I don't know, you're probably right. You probably know more about ACT than I do. You know, my job today is to hopefully just sort of sell it a bit in terms of that acute environment. And I also just wanted to mention that it's not for everyone. You know, it's not perfect. I don't think there's a model or an approach that is. You know, I think my style, as I'm sure many of you guys are the same, my style is to work in quite an integrative way. And what I've tried to do in preparing for this session today is to think a little bit about, I guess, the ideas from ACT that might be appropriate to fit into this kind of a context, and that we might be able to bring into this world alongside all the other things that we know about. So in terms of the neurosurgery wards that we work on, so we kind of have, I'll tell you a bit about the setup. There's 3 of us in a small team who work across a couple of different wards in the hospital. And we typically work with a variety of presentations, but these are some of the most common. So we work with a lot of tumour patients in terms of people who've come in for either operations that are planned elective operations to reduce and resect some of the tumour, or sometimes people who are at the really early stages of their journey and who are kind of going through that initial diagnosis phase. So they might just have a biopsy done, and some of that would be sent off to the lab so they can gauge what type of tumour it is, that kind of thing. We see a lot of folks who've had traumatic brain injuries, and we see a lot of people who've had what I've called here sudden onset ABI, so lots of different kinds of brain injuries that go on. Some of the most common subarachnoid hemorrhages, AVMs, ICHs, things that kind of just happen quite out of the blue with a little warning. And I think that's important to kind of just mention that sudden onset aspect of it, because I think that's a very different psychological experience for something to just happen out of nowhere than for something that is a more gradual onset kind of condition. We also see a lot of kind of what we would say more functional kind of syndromes, things like chronic hydrocephalus, things that more generally affect somebody's general functioning, and that might require surgical intervention. In terms of our actual ward context, we're split across a couple of wards, as I mentioned. I tend to work on one particular ward, which is kind of a mix between bays of 4 beds along with some side rooms. So it's a very acute medical ward. We have a lot of folks in that ward who are quite medically quite poorly. We tend to take step downs either straight from surgery or from critical care. So people are still quite unwell. They're not quite as unwell as what they were perhaps if they're in the intensive care unit, but they're still quite unwell and still need quite a lot of medical intervention. But what we're also trying to do is think about discharge planning and step down, whether that's to some sort of inpatient rehab sort of setting, or whether that's a discharge home with whatever support they might need. So in terms of the referrals that we get through to our neuropsychology service, I've again kind of grouped these very roughly. These often kind of present together, but typically we see a lot of referrals coming through around anything to do with mood, coping or adjustment, for either in the immediate aftermath of the surgery in relation to the condition itself, or to any of the complications that arise. We get quite a lot of referrals for people who need further assessment. So a lot of that's that kind of disentangling process of understanding maybe what's changed after the surgery, or to do with the condition, any new impairments or deficits that somebody might be starting to experience. A lot of our role is to try and help the team to disentangle some of that. And some of the work we might do within that might be around working with people who are in what we call a delirium sort of phase. So trying to understand what somebody's kind of behaviour is about really, what are the medical things that might be contributing to that, and what the psychological factors might be contributing to that. As I mentioned, we've got a role in thinking about onward care planning, discharge planning. So we work quite closely with our occupational therapy colleagues to think about whether somebody's safe to go home, whether somebody will be able to manage at home, and if so, what kind of help would they need, or whether a period of inpatient rehab would be useful and appropriate. And we also get involved quite a lot as well with mental capacity assessments, often around people's capacity to make decisions about staying in hospital. Sometimes people decide they've had enough of being in hospital and they want to go. So it's our job to try and help with that process of just checking out their capacity to make those kinds of decisions. Sometimes we get involved with other decisions as well, around things like capacity to consent to surgery. So that can be quite varied. I think I just wanted to mention some of the typical challenges, because it's definitely not the environment for in-depth one-to-one therapy a lot of the time. You know, as I mentioned, that they're either bays or side rooms, the medical wards, so they're noisy, there's things bleeping, you know, we have a curtain around us often. It's not exactly as soundproof as we might like. People are kind of constantly coming in with injections or tablets or meals or any of the other kind of things that you might get in a medical ward. Often we're working with people who are really medically poorly, so they're often in the very early stages of the recovery. It can be a matter of hours or days after they've had their operation, so things like fatigue is often a really significant factor here, as well as other symptoms that might just be a kind of natural effect, things like nausea and what have you, things that are just going to get in the way of someone's ability to have a kind of useful psychological type conversation with someone like me. And the other thing I want to mention as well is that people often aren't on the ward for very long. So because we have this role as an acute ward, We obviously want to make sure we get people coming through and moving on as much as we can. And if you've ever worked in an acute hospital, you know that you live and die by the patient flow. So we often only have patients with us for quite a short period of time. That might just be a day or two. It might be a couple of weeks if they're waiting for a rehab bed. But it's definitely not the time or the place to be doing lots of long-term, in-depth psychological therapy type stuff. So a lot of the folks I see, I might see just once or twice. So again, I thought that sets a useful context for trying to bring some of the ACT ideas into that. So just to mention a bit about ACT, I'll gloss through this because I know you've heard a bit about this already, but I just thought I'd include it. So as you know, ACT kind of really driven by Stephen Hayes, did a lot of work on language and thought and how that influences our internal experiences. The focus is about thinking about accepting what's out of our control and thinking about committing to actions that can improve and enrich our lives. And again, just a big shout out to Russ Harris, because I think the materials he puts out there are brilliant, and I've definitely stolen a lot of them for the session today. I really like this description. You know, the aim isn't to reduce symptoms or problems. The aim is to change the person's relationships with symptoms. And I think that really fits nicely with the acute neurosurgery context. I think we're often working with people who are just at the very early stages of getting their heads around what's going on. So the idea that we could make somebody happy or less distressed doesn't really make sense. It wouldn't really fit. So I think this is a really nice, almost philosophical starting point for me in terms of what we're actually there to help with. But that's unusual. That's a bit of a paradigm shift, I think, for many psychologists. I've pinched this from the Happiness Trap, which is Russ Harris's book. He talks about the myths of happiness, about how happiness is seen as being our normal, natural state, and that we should be happy all of the time, and that if you're not happy, there's something wrong with you. And I really like starting any kind of work by acknowledging that that's a bit of a nonsense, that's a myth. And that gives us a nice role for ACT in this context. You know, thinking about how within the pain and suffering that we might be going through, we can still find opportunity to find meaning and purpose in our lives. I really like this quote about emotions being like the weather, continually changing. I'll come back to that a bit later on when thinking about emotional ability. But ultimately, what I really like about this approach, and I think what attracted me to this approach in the first place, is that life is difficult. And when we're working with people with really serious long-term health conditions that they haven't asked for, they didn't want, they didn't deserve, you know, it's really important that we acknowledge right from the start that life is difficult, life is unfair, and there's a lot of challenges that go along with that. As you know, if you're probably watching this, you know, lots and lots of research and materials out there around the role of ACT in supporting people with long-term health conditions of various different types. I think this book, if you've not read it already, is a fantastic resource, just in terms of kind of bringing in some of those ideas. This is one of the first books I read around some ACT kind of ideas, and I thought it just really helped me bridge that gap between what my CBT kind of starting point, that, to be honest, felt quite limited in working with people with health problems. It helped me bridge that gap a little bit, so I'd really recommend that. Just building on some of those myths of happiness, you know, again, this is something that Russ Harris talks about quite a lot, you know, thinking about the emotional experiences that go along with happiness and acknowledging that life isn't just about happiness, acknowledging that there are things, other emotions, things like frustration, anxiety, sadness, guilt, that go along with some of the more positive experiences in life. And I did this exercise in a teaching session I did a few months ago, and I asked for examples from the people listening, and one of the fellas chatted about proposing to his partner, and it was just a lovely example of how the biggest thing he'd ever done in his life, the most, you know, usefully values-driven thing he'd ever done in his life, was utterly terrifying and was fraught with all of these obstacles that he had to overcome to be able to get there. But when he told the story, that wasn't what he remembered. He remembered the outcome. He remembered that she said yes. He remembered that it was a really positive thing. I think, again, pinching off some of Russ Harris's stuff, I think the idea that we can live a full life that isn't just about happiness, the fact that we can bring that full spectrum of emotions into our life and acknowledge that and appreciate that and value that, I think is, for me, what attracted me to ACT in the first place. And the things that ultimately we want to do in our lives, the things that give us value and meaning in our life, are the things that have some of those more difficult emotions associated with them as well. So thinking about how some of that might fit with the neurosurgery context, you know, a lot of the folks that we're working with in this context have had really long-standing struggles with things for years. You know, they've come in for sometimes the 8th, 9th, 10th operation. You know, they've been battling the condition for a really long time. Or sometimes people were absolutely fine last week, and then this week they're really, really, really poorly. Sometimes we work with people who have got a new diagnosis following some pretty vague symptoms. So somebody might have just had some headaches, or they might have just had a bit of nausea or some dizziness, they might have had a seizure. They've gone along to the GP and thought, there's something not quite right here. And then that's led quite quickly to a really serious life-changing diagnosis. And I think that can happen so rapidly that people don't have time to figure out where they are with that, you know, that they just don't have time to stop and think. And being able to, I think, come to terms with that is incredibly tough for people on the wards. I think a lot of the time while we're working with people, you know, particularly after an operation, there's a lot of uncertainty. Some people often don't know what's going to happen next, either in terms of their diagnosis and the trajectory of their potential recovery, or they might be potentially looking at a more palliative kind of diagnosis. There might be a lot of uncertainty about whether they need more rehab and need to stay in hospital for longer, whether they are able to get home, whether they will be able to manage at home, whether due to cognitive impairment or physical impairment. A lot of the people that we work with are just really struggling with actually just being in hospital. Being in hospital isn't easy for a lot of people, I'd say for most people. Some people really, really, really struggle with it. And you know, we've worked with people on the wards who've had very, very negative, difficult associations with hospital. Maybe they've had relatives earlier in their life who passed away in hospital, and therefore coming into hospital and being there, being out of control is incredibly difficult for them. And to be honest with you, I think what I often start by is acknowledging that context is really tough for anyone. You know, you're out of control, you don't get to pick when you eat, you don't get to pick when you go to sleep, you're woken up for injections or blood tests or temperature checks every couple of hours. It's a really tough environment to be in. You've got no control over who's in the bed next to you. You're not able to do any of the things that you normally do to keep yourself well and to manage whatever emotional experiences you've got going on. I wanted to acknowledge all the physical impairments again, that this can often happen after a surgery. Somebody potentially might have quite new physical impairments that can be very life-changing. So thankfully it doesn't happen too often, but sometimes we work with people who have come in for a relatively routine operation, and then something's gone wrong in surgery. Maybe they've had a bleed or a stroke, or something's happened in the surgery context, and that's left them with things like weakness or even paralysis down one side of the body. So that can be incredibly difficult for people to get their heads around and come to terms with. And I guess similarly, the cognitive impairments can be really difficult as well, you know, and these are the things that often we're trying to figure out in that acute neurosurgery context. We're trying to get to the bottom of what's actually going on, you know, it's really tough to figure out whether somebody's got any problems with things like memory or attention or processing speed or executive function. Any of the more typical neuropsych assessments we might do aren't really appropriate to use in that kind of a heavily medical acute context. So it can be really difficult to understand that. And then it makes it really difficult to explain that to the person and to the families. So people are often just at that really early stage of figuring out, right, what am I actually dealing with here? What am I dealing with? And that's sometimes made more complicated by issues around insight and awareness. You know, if people aren't able to recognise that they are a bit different to how they were before, that can make that process even more challenging. And I just wanted to acknowledge the COVID impact as well. So the biggest challenge for us on the wards has been that we've had to put a stop to a lot of visitors. So, you know, that's the predominantly main thing that gets people through being in hospital is, you know, having the visitors from the partners or the children or the families. And just to suddenly go from having no visitors allowed apart from kind of more exceptional circumstances, you know, that's made it incredibly difficult for us to try and help people just cope with the normal emotional struggles of being in hospital. Yeah, this is my dog. This is Lucy. I just wanted to throw this picture in. I don't really have a reason for it. It just made me laugh. When I got this book through the post through Amazon, this is The Reality Slap by Russ Harris. Lucy got to it first, and I don't really know how that fits with anyone I'm talking about. I just thought it was an amusing picture of, you know, there's a reality slap for you. Anyway, So what I'm going to chat a bit about for just this next bit is just some of the core principles of ACT. I'm not going to go through all the theoretical stuff because I know you've heard that a bit already today. What I'm going to try and think about is just maybe how some of those ideas can fit within this kind of a context. So I think, as we kind of touched on, we know that suffering is a universal, natural, inevitable condition for human beings, and we know that through some of the challenges that I've just mentioned, that would be a very understandable, normal response. An ACT perspective would be that some of the distress that we experience maybe comes from an instinct to try and get on top of that and control that. And that can be the thing that keeps us kind of stuck in the mud. The more that we push and the more that we try and rail against that, the more that we can end up struggling. You've probably seen this a few times now already. This is the hex flex, which I think just acts as kind of a nice little roadmap. And you know, I would very rarely use this in a full therapy sort of way. I would never show this to people in a ward setting, but I think as an internal thing for me to just hold in mind, I find this really helpful. It's kind of, right, what am I trying to do in this conversation? What am I trying to touch on? Thanks to Richard as well, because I've pinched your picture there. So cheers for that. I much prefer this simplified version. This is the triflex, which I think Becky mentioned a bit earlier. I find this a bit more easier to get my head around. As I said, I'm not very good at models, but I just really like these principles about being present, thinking about where we are, opening up to more difficult experiences, and then ultimately doing what matters. And I think even in and amongst all the complexity that I've touched on of working in really acute medical settings, I think these principles are things that I regularly come back to, just in terms of, right, okay, what are we going to do? How are we going to try and help? I'll say a little bit about acceptance. Again, I'm not going to go through this in loads of detail, but some of the things that I kind of draw on quite a bit are around the language around acceptance. I think can be quite tricky, especially in that really acute phase, in that I would hate to give somebody the impression that I'm trying to tell them they need to accept what's going on, because I don't think that's what's meant here, but I think that's how people could take it. So I definitely had a big warning flag to say, think about your language here, think about how you word it. But I think what we can do is we can help people to open themselves to the experiences that happen. And this is a question I ask quite a lot. What would happen if you stopped struggling against this? And often people in that really acute phase are just in essentially fight or flight mode. You know, they're often just so angry and so upset that it impacts on the way that they deal with the people around them, impacts on the way that they deal with and speak to the doctors, the nurses, the therapists, impacts on the decisions that they make, impacts on the way that they speak to their families. And I think sometimes just helping people to think, right, okay, we're in a really difficult situation here. What would happen if we just pause, stop the struggle, take a bit of a break? And again, if we were in real life, I'd show you this balloon exercise, which I think is a Russ Harris thing again, I think. But the balloon exercise is really, really nice practical thing to do. And sometimes I won't do this on the wards practically, but I'll talk people through it. And essentially just as to hold a balloon out in front of you, and for a minute or two, it's okay. But over time, you get tired, and what started off as something that didn't have any weight at all becomes really, really difficult the more that we have to hold it out in front of us or above our heads. Okay, so I always try, whenever I'm talking about, you know, acceptance, always try my best to define it with people and think about, okay, what are we actually talking about here, and try and do this as a bit of a conversation, and that it's not about self-defeat, it's not about letting the pain or the distress win, it's not about giving up. And I think that's especially pertinent when talking about things like tumours and cancer, because I think there's a very much a narrative in our society that we have to fight back against cancer, we have to battle it, and that's so much wrapped up in the language that we use. You know, we constantly hear things like, you know, he was a fighter, or she's lost a battle with cancer, and I just think that's a really rubbish kind of narrative to have a lot of the time. So I think I often try and, whenever I can, challenge people a bit to think about, well, okay, what would it look like if we were able to embrace where we were at rather than being caught up in that struggle? I think we've got to do that from a very curious, gentle kind of position. I don't think that could be a confrontational conversation. I think that needs to come from a point of just trying to help people have a bit of space and time to think about where they're up to. I think this is another really useful idea. This is a Stephen Hayes quote. I think sometimes I'll get brought in to see somebody because they're, well, thinking about things too much, or they're thinking about things a lot, or they're really upset or really distressed. And people will say things like, I just want to not think about it for a while. And I think you've probably come across things like the pink elephant metaphor. And I think for me, this just encapsulates why this is useful. That the more that we try to not think about something, that's still a rule that's in our mind. So if I'm saying, right, I am not going to think about this, then I am going to think about it. So the more that we try and suppress our thoughts, the more difficult that's going to become, the more we're going to think about it, the more worrisome those thoughts are going to be. So I think being able to, again, explain and normalize that to folks can be a really useful thing to do, even just in a quick conversation. That, okay, let's try stop this struggle of not trying to think. Let's try and do something a bit different. And as well as that, you know, being in hospital, especially in an acute ward, it means you don't have a lot of control. You know, you don't have a lot of say in what's happening. You are very passive. For those of you who've ever been in hospital or have had a loved one who's in hospital, you know, as much as we try and be patient-centered, as much as we try and give choice and autonomy, you're still very much out of control on a lot of the day-to-day things that happen, just in terms of when you have your tea, or when you get offered a brew, when you get your tablets, when you get your medication, when your physio sessions are, anything at all is kind of not up to you, really. So no one likes that. That's not good for anyone. But I think a lot of the challenges that we see on those wards come from people really trying to regain a sense of control. People, you know, really struggling in some way to find that sense of ownership of their lives again. And again, sometimes just having that conversation with people and saying and acknowledging that, yeah, there's a lot of this that isn't within your power at the minute, and there's a lot of this that you can't really do much about. What is within your control? You know, I think that can be a really helpful conversation. This kind of taps into some of the ideas around experiential avoidance and how that can affect people's ability to be what we call psychologically flexible, which I'm not going to get too much into because I know that you've heard about that and other things, but I think it leads nicely onto metaphors like the struggle switch. So if you've not come across this already, Russ Harris has done a really nice video on YouTube about explaining this really well. This idea that we can make the conscious decision to pull away from that struggle. We can, instead of being caught in the tug of war, we can put down the rope. And I think even just in those quick, easy metaphors that people often can intuitively grasp, I think that I've found works really nicely. You know, experiential avoidance in this context, I think typically for me falls into two categories. We get people who will say things like, I just can't bear thinking about what's going on for me. I just don't want to let myself think about it. And that can be all right. You know, that can be a very practical, very useful way of coping in those early stages. And I wouldn't want to challenge somebody on that. I think sometimes it can get in the way, especially if it means that people then aren't able to do things that they would normally do, aren't able to think about maybe talking to the family, or aren't able to think with us about where they want to go next and what rehab needs they might have and all that kind of stuff. So sometimes that avoidance can get in the way of them actually moving forwards from wherever they're at. I think sometimes we see it in more practical ways as well, through things like people refusing physio sessions or kind of avoiding that. And I think, again, sometimes we'll get brought in to try and do things like joint sessions with the physios to just try and help people feel a bit more able to open up to giving some of these things a go, even though they're difficult. You know, if you've ever had a physio session, you know, most physios, I think, will be all right with me saying that most physio sessions are painful, they're uncomfortable. You know, they have to be, you have to push yourself in those sessions. So it makes sense to avoid it. It makes complete sense to steer away from that wherever possible. But that might not necessarily be consistent with getting you to where you want to be. So I think these ideas and these concepts fit really nicely. There's a really nice video on experiential avoidance if you want to see a bit more on that. I really like the tools, again, it's another Russ Harris thing, but I really like the idea of creative hopelessness as well. And I think this is, for me, one of the most useful elements of ACT. There's a really nice handout that Russ has put on the website there that's worth a look. And I try and integrate these ideas into conversations quite often, because I think often by the time people come to see someone like us, they've tried a lot of things already. And I think this is really true. Even if someone's just been on our ward for a couple of days, I'll often still work these kinds of questions into the conversation if the person's up for it. Because I think it's really important to acknowledge that if somebody's really struggling emotionally, then they've probably already tried a lot of things to cope with that, whether that's distracting themselves, whether that's trying not to think about it, whether it's you know, locking the door and putting the head under the pillow, you know, whatever it is they've probably tried something, and there may have been some elements of that haven't been helpful, or that have maybe taken them away from where they want to be. And I think this can often set up a really nice dynamic in terms of just fully, genuinely acknowledging and validating what somebody has tried already and the efforts that they've gone to before they get to a point of speaking to someone like us. I think metaphor comes in really handy as well, again, in these brief kind of conversations that we often have. I think, again, if somebody's cognitively able to engage on that level, I think these can explain the concepts in a much more useful way. So I really like this metaphor of a monster being on the other side of a cliff trying to pull you in. So I think this comes from the kind of chronic pain world, but I think it fits really nicely when talking to people who are just caught up in this struggle against the system or against the situation. So an example that springs to mind would be somebody who is just refusing to do anything, doesn't want to do any physio, doesn't want to talk to doctors, doesn't want to think about going home. It's just completely, I can't do this, I can't do any of it. And sometimes being able to think about the fear and the anxiety of what's coming next as a monster that's trying to pull you in, and your only response to that is to dig your heels in and pull back. I think that's a really nice way of conceptualizing some of those feelings and some of those responses in a way that then opens up the door for thinking, well, okay, what can we do next? And a similar metaphor that I really like is the idea of being stuck in quicksand. So apologies for using this picture because it's from definitely the worst Indiana Jones film that there ever existed. But there was a really nice moment in this film where, for those of you who don't know, Indy gets caught in quicksand and he's sinking and it's all a big disaster. And the way that he manages to get out of quicksand, ultimately, sorry, spoilers, the way that he manages to get out is to grab onto the thing that his son throws him, which just so happens to be the only thing he can find, which is a big snake, which just so happens to be the one thing that Indiana Jones is afraid of. So I think it's a really nice metaphor for thinking about when we're caught in a struggle that's pulling us down and sucking us down. Sometimes we do need to take action, we do need to do things a bit differently, and sometimes that means embracing and directly doing things that are difficult or frightening or scary. And that's something that we can acknowledge and validate and think about in a compassionate way, but I think it's something that we can support as well. So yeah, I think that's quite a nice little metaphor to bring in. And my last little metaphor, this is my dog Lucy. She's quite young here actually, she's a bit older than this now, but this picture was from the very first time it snowed in Manchester during her life, so it was only a couple of months into me having her. And we opened the door in the morning to go for a little walk around the park, and there was all this weird, cold, horrible, wet, white stuff everywhere. And she was terrified. She did not know what to do. She put a paw in it and hated it. It was cold. She ran back inside. She came out again with much encouragement and put a nose in it and ran back inside and just was not for having it. It took a bit of time. It took a bit of encouragement. It took lots of biscuits and lots of treats, but eventually we were able to slowly, gradually move forwards into that thing that was new and frightening and unpleasant. And we ended up having a great morning, chucking snowballs around and running around. And I just think this picture for me encapsulates how happy she was by the end of that, you know, she ended up loving it. But we never would have got to that point had she not been willing to embrace a bit of that unknown. And it's not always easy as that, obviously, but I think by being willing to take that chance, by being willing to give things a go, we can hopefully open up stuff that can be more positive. And I think for me that kind of taps into, again, some of these ACT ideas about our role in helping people feel able to embrace a bit of that willingness. And I think Becky mentioned this in her talk as well, but it was a point I really want to make. I much prefer the word willingness to acceptance, because I think often the things that people are going through are unacceptable. How can you accept being 30 years old and then finding out you've got 3 months to live? That is unacceptable. The word acceptance just doesn't fit with that in my mind, you know? So I think shifting the emphasis a bit to, okay, what is within our control here? What can we do? And are we willing to do some of that stuff? By focusing on that change and focusing on what we can have a bit of a control and ownership of, I think that can lead to positive stuff. So yeah, just summary points there. Acceptance can be an alternative to some of that experiential avoidance. By trying to get rid of some of that pain, we can actually maybe amplify it and make it worse. And we can hopefully help people to move forwards with that. But what I'd really emphasise is that rapport is key there, and I think we need to be able to do that. We need trust, and we need to be able to be honest with the folks that we're working with, and we need to be validating where they're at and meeting them there, rather than trying to impose our views on them. In terms of kind of how that fits with adjustment, I think often we're working with people at the really early stages of this, so I think I'm always really mindful to try not to get in the way of that too much. I think there's a very normal process of emotional adjustment in terms of just getting your head around something that's going on. And it's a bit of a cliche, but the only way of doing that is to have a bit of time to process it and come to terms with it. So I think a lot of our role in those early days is just about helping people put the pieces in order, helping them to make sense of what's going on, making sure they've got an understanding as much as they can about what's happening, so that they can then take that forwards and carry on that process after they leave the ward. There are lots of things that get in the way of that. Maybe their medical status, if they've been quite poorly, perhaps if they've been in and out of consciousness, or have been just had other challenges going on. If there's cognitive impairment, if there's communication impairments, if there's anxiety, there can be lots of things that can interfere with that process of adjustment, and that can really slow it down, I think, and really get in the way of that. So I think being able to think with people about just what's going on as much as we can in that early stage, I think it can be really useful. I think being able to help people to think about how we support them without getting in the way of it. What I mean by that, I think, is often just about giving people time and space to talk through where they're at, and almost just hearing that, listening to it, hearing where they're up to, and then working with them at that level. If somebody isn't at a point where they are ready to accept or be willing to do different stuff, then it's not our job to push that. I think it's our job to try and validate that as much as we can, and then present what the next phase of that might be, and then it's up to them to take that forwards beyond where they're at. I really like this one, again, to give a bit of a shout out to Fergus Gracie. I really like this model, and I think I don't quite have the language for this or the brains for it, but I think there's, on some level, this fits with Fergus Gracie's model, the Y-shaped model, because I think ultimately, adjustment and adaptation to after a brain injury, this model would argue, is it's kind of about, giving stuff a go. It's kind of about doing stuff, learning from it, and then working towards a more, cohesive self-representation, self-identity that's based on what can I do now? What am I good at? What do I need a bit more help with? And I think often when we're working with people on the wards, we're at the really early stages of that. And I think sometimes just being able to shift the emphasis around things like, for example, a physio or occupational therapy session, shifting the emphasis of, okay, well, let's just try it and see how we go, because we're in that process of just learning and figuring out what your problems are and what you need a bit more help with, or what you're good at. Shifting the emphasis to that, I think, can be a nice way to just set the tone for that early adjustment in those phases. And thinking about how experienced opponents might get in the way of that, I think I've touched on this already, but thinking about how engagement might be limited, thinking about how we can improve that. But I think also sometimes the systems that we're working in can maybe reinforce some of that stuff as well. So I think we're really lucky in the teams that we work in. We've got very, very good, very compassionate medical and nursing teams who are really what I would call psychologically minded, very switched on to anyone who's struggling emotionally or anyone who seems to be not in a good place, and they're really good at making referrals to us for that. I think sometimes we need to be cautious that we don't just come rushing in, and I think it's important that we respond thoughtfully as a system rather than just reacting, because I think sometimes if we give people the message that these emotional responses are in some way wrong or problematic, or I think we can really easily pathologize this stuff. So I think a big part of what we try and do on the wards is to try and work with the patient in the bed, but also to try and work with the team as a whole to think about how we can support people as a whole during the time there, and to really reinforce messages like, riding the wave of it. People's emotional responses is a part of everybody's role. Everybody who comes onto the ward has a role to look after the emotional well-being of the folks that are there. And if somebody gets distressed, that's not because we've failed as a team. It might mean that we need to respond a bit differently, but somebody getting distressed or upset isn't something that we need to jump in and try and fix or cure. I hope that makes a bit of sense. And I think that kind of links into how we take referrals as well. So we've had lots of conversations about our referral system. We have an electronic system that people type the thing on the computer and then it pops up on ours. And what we're trying to shift towards is to make it more of a conversation, to make it more of a discussion between the referrer and ourselves, so that we can think together about what the whole team can do in terms of looking after somebody's emotional well-being while we're on the ward. We do a lot of thinking about how to normalise, how to validate, how to just be with somebody and help hold and contain where they're at, rather than trying to jump in, trying to fix it and resolve it. And again, to me, this feels very driven by some of my ACT kind of knowledge. We do a lot of work typically with the medical and nursing teams, with the therapies teams I've touched on, but with families as well. Obviously that's been made a bit more tricky in COVID times, but we do quite a lot of thinking, hopefully systemically, about what we can do to try and help everybody involved with somebody, how the system as a whole can help respond to that in a useful way, and hopefully get away from this idea of just jumping in and reacting and trying to fix somebody's emotional responses to something that's just really difficult. I'm mindful of the time, so I'm going to skim forwards. I'll send these slides over so you can have a look through them if you want. I was going to talk a bit about language and stuff, but I might gloss over this bit. The thing that I guess that maybe is worth touching on is about the language that we use on the wards, about kind of how we often have associations with pretty negative stuff. So as soon as we say a word like cancer or tumour, people have got really strong associations with that, and that can be unhelpful. So being able to ask people questions about their understanding of their symptoms or their diagnosis can be really important. That can go alongside, again, I was going to talk more about this, but we're out of time. I was going to talk a bit about some of the social stigma type stuff around that as well. So if somebody has a physical impairment, often they will have internally some sort of really negative understanding of that, about what that means. I worked with a fellow recently who had quite a new physical impairment, and his immediate response was, well, I'm a cripple now, I can't do anything. And actually being able to talk about that and name that and think about that was really important in him being able to see that actually there might be some recovery potential, and that even if there isn't any recovery physically, he could still potentially adapt and adjust and live the life that he wanted to live. The other thing I say as well actually on that is just, again, a similar idea, but a lot of people really fused with the idea that the medical condition is their fault. So, and again, this is really reinforced by social narratives, but a lot of the people who I work with who've had brain tumours will often ask questions like, what have I done to cause this? Is this because I eat McDonald's and don't exercise? Or is this because I don't know, I took this medication? Or is this, whatever. And often a really useful thing to provide a bit of education on is no, this is just bad luck. This can just happen to anyone, and it's not caused by anything. It's just one of those things. And I think that can be a really important thing to unpick with somebody if they're really fused with the idea of, this is my fault, I'm to blame for this. So that kind of taps into this idea that our mind isn't always on our side, isn't always our friend. I'm going to skip forward a bit, if that's cool, just because I think other speakers have touched on this stuff. I think Becky spoke a bit about mindfulness as well. I tend not to do loads and loads and loads of stuff on mindfulness, but I think what we can do on the wards is create a space for mindful noticing of thoughts, and I think that can be a really useful thing. And I think for me that there's that difference between being in the forest and being surrounded by trees and being above the forest and being able to see the trees. And I think we can use analogies like that to help people understand that by noticing the thoughts that we're having, that can be that can create more opportunity for doing things differently, compared to just being completely overwhelmed by them. Often even just in one or two conversations, trying to ask questions like, what's your mind telling you right now? How are you finding that? Is that helpful? How would you want to respond to that? I think often I use language like that rather than asking questions that might come from more CBT type discussion, because I think that opens up a bit of space to do something different. And for me, those kinds of conversations are fundamentally about creating a bit of space for reflection on where is your mind right now? What's your mind doing? And just creating that little bit of distance can be really useful, I think. And just a couple of examples, I'm a failure compared to the thought of I feel like a failure because that physiotherapy session didn't go well. Those are two very different types of emotional experiences that will be attached to those things. So I think creating that bit of space can be really valuable. And, you know, ultimately, it's kind of reinforcing this idea that thoughts are just thoughts. And I think, you know, as psychologists or as mental professionals, we're kind of probably quite familiar with that idea, but a lot of people don't think about that. You know, a lot of people very rarely think about what the thoughts are. They just have them. They're not aware of it. They're not consciously thinking about it. So being able to just say, oh, okay, what's your mind telling you right now? What's your mind doing right now? Where's your mind right now? Those kinds of questions, I think, can come in really helpful. There's lots of good metaphors, loads of good stuff on YouTube to help with that. One that I've kind of used quite a bit is the idea of taking a penalty in the World Cup final. I really like this idea of, you know, having this really important thing to do. You've got the world watching you, you've got all this pressure, you've got this really important thing to do. You've got half the stadium screaming abuse at you, saying you're going to miss it, you're going to do it wrong. You've got half the stadium really saying, you're going to do this, come on, we need you to do this. And how do you respond to that? How does your average, you know, superstar footballer manage that? And probably what they have to do, I don't know, not being a superstar footballer, but probably what they have to do is find some way to tune away from that and focus on the task at hand. And I think analogies like that can be really helpful in just, I guess, helping people to think about where is your mind at right now and how do you want to respond to that. I really like this exercise as well. Again, you may have seen it before, but I really like the idea of noticing a thought, writing it down, and then writing down, I am having the thought that, and then writing down the thought again. And then writing down, I am aware that I'm having the thought that. And again, just that idea of creating a little bit of space from the thoughts that we're having, I think can be something that can be done, again, just in 1 or 2 conversations, even at a bedside. And even if the person can't write because of physical or whatever, that's still something that can be part of a conversation. Again, I'm going to gloss through this quite quickly just in terms of time, but some of the other analogies around, you know, being able to externalize and you know, drawing on some of those kind of narrative therapy type ideas, externalizing, giving your mind a name, seeing it as an external thing that sometimes it's helpful, sometimes it's not, sometimes it tells us useful things, sometimes it doesn't. Sometimes it tells us things that are just quite offensive and we can just kind of ignore it, and that's okay. You know, being able to balance that with sometimes actually it might be quite helpful to see our mind as something that's looking out for us. And a fellow that I worked with on the wards quite recently, that was where we got to. He was really, really super anxious about this really big operation that he had coming up. And you're kind of like, well, yeah, of course your mind is warning you about all the things that could go wrong there. That's what our mind is there to do. That's what our mind is designed to do. It's designed to keep us safe. And you've got this really life-threatening thing on the horizon. So of course your mind is going to be going through all the worst case scenarios. That's how our minds try and keep us safe. The question is that helpful? And when does it stop being helpful? And when does it start to get in the way? And for him, it was starting to get in the way. So that's when we start to think about, okay, well, how can we do something a bit different with that? Again, if we were here in a room, I would encourage you to have a go at some of these kinds of exercises, you know, thinking about some of your most difficult personal thoughts that you would have, some of your most self-critical, deep thoughts, saying, would you want to write that down on a bit of paper? Would you put it on a t-shirt and walk around with it? Probably not. You know, these things that are really difficult to shine a light on, and often it takes quite a lot of conscious effort and energy and willingness to be able to do that. So I think we need to be able to kind of validate that that's difficult, but also try and encourage people wherever we can that talking that through, shining a light on it, maybe sometimes can be helpful. And maybe this is from a more kind of CFT type of world, but I really like asking people to imagine themselves as a small child. And if you were, you know, imagine that the child part of yourself, how would you respond? How would you say that? How would you respond to that? Okay, just wanted to touch on as well, I noticed a couple of questions on for Becky's talk touched on this. I think it can be really incredibly difficult to work around people with cognitive impairments and bring in some of these ideas, because they are quite, I think, vague a lot of the time. They're quite tricky to get your head around. So just some of the practical things that we do that I think maybe links to ACT in some way, shape or form. You can be the judge of that. But we really like encouraging families to record messages. So this can be really anything. We've had some good success with people recording things on the phone that just say things like, you're okay, you're in hospital, you're safe, we're here for you, we're looking after you, we'll be coming in to see you later in the week. You can ring us if you need anything. And just having that as a voice memo that somebody can just play, and just hearing that familiar message from a loved one can be really powerful. And I think you could probably bring in some theoretical stuff about language and thoughts in that, you know, in that by targeting that level, you're helping people to think about their own thought process as well. Really just anything that's useful. I think as well, I think we really encourage our staff teams to think about the non-verbals as well. So an example that I often encourage people to think about is, for staff teams, is if you, as a nurse or as a doctor or as a physio, if you were poorly, if you were unwell in a country where you didn't speak or understand any of the language, any of that was being spoken around you, what would you want? What would you still want to see? And usually people are able to name things like, well, I'd want to make sure that I could express my urgent needs. If I needed to go to the bathroom, then I'd wave and somebody would be responsive. I'd want people to smile at me and nod, even if they didn't quite know what I meant or didn't quite know what I was saying. So things like that can be really, really powerful, just in terms of helping the system around the person to be able to cope as well as they can. We do a lot of joint working with occupational therapy and speech and language therapy, which is really important in terms of, I think, bringing in the expertise from our colleagues, you know, but I think hopefully what we tend to find is the sum is better, greater, whatever that phrase is, some of the parts, you know, it's better working together. We end up getting more of it because we bounce ideas off each other, and I'll say something, they'll say something, they'll say something, I'll say something. We end up, I think, getting to a better place by working collaboratively. So I think that's a really important thing to do when you're working in any kind of acute environment. And then just practical adjustments as well, you know, things like using pictures or images instead of words, you know, actually having visual representations of the things that we're talking about, you know, picture of somebody being distressed or somebody stuck in quicksand, or really anything to support what you're trying to say, just those things to just facilitate communication, to make it a little bit easier. Adjusting that for COVID-19 has been really tough, you know, predominantly because we're all wearing face masks. So that completely strips out a big part of non-verbal communication. So again, I think it's really, we're still all getting used to it, but I think just about trying to encourage people to really focus in on the things that we can control, the things that we can do, the things that are more within our control, things like our eyes, our eyebrows, that kind of stuff, and just being a bit more explicit about things that would have usually been implied. I'm going to skip forwards. I just wanted to touch a bit on kind of present moment stuff, just really because for a lot of people in these situations, contact with the present moment is the last thing they want to do. Sometimes the present moment is awful. I think I've learned to be a bit careful with talking about mindfulness, because for some people it works really well in these settings. For some people it's just too much and they just can't handle it. Even the most simple exercise is just too much and it's not practical. So I think it's something you've got to kind of learn to have a bit of a tentative light touch with, I think. I try and focus a bit more practically on whatever works, you know, minute to minute, how can we get through this bit? This is a really tough time. How are we going to get through it? Is it about distraction? Is it about putting the TV or the radio on? Is it about ringing family? Is it about getting, I don't know, a book or doing some colouring in, doing anything at all that's just going to get you through minute to minute, hour to hour, day by day? Trying to encourage people to, if they need to dive into the emotion. If you need to have a cry, have a cry. If you need to get angry at somebody, that's okay. But sometimes just being so determined to hold on to, you know, I'm coping well with this, can be part of the problem. Whatever you do it on purpose, do it deliberately. Let's focus on controlling what's within our control, controlling our behaviour. I think, yeah, actually doing mindfulness exercises is tough for anyone. It's for me, I'm rubbish at it. You know, I think we naturally don't do it very well for a lot of people. You know, I think it takes a lot of practice, takes a lot of expertise to be able to do it well. I think in this context, I think it's about just trying to help people to get a bit of a break from whatever really distressing, powerful thoughts they're having, rather than trying to get completely, you know, perfect at it. Just to say, I think a lot of people struggle with mindfulness stuff. I'm in the process of, it's a bit of a working process, but in the process of putting together a website, to kind of acknowledge how rubbish I was at mindfulness when I was training, and still I'm a bit rubbish. So my website is going to be called You Suck at Mindfulness, and it's going to be featuring purely exercises that are a bit more simple, a bit more concrete, not fluffy and waffy, just really concrete, simple things that we can draw on. So if anyone's got any good ones, feel free to email me. This is hopefully going online soon. The way that I tend to sort of talk about mindfulness on the wards is, you know, to just, again, a bit, to keep it focused on thoughts and feelings, really, you know, to think about, as human beings, we're great at getting stuck in our heads. We're great at predicting the future or thinking about the past, remembering the embarrassing and shameful stuff that's happened to us. And just mindfulness for me and being in the present moment is about just putting that to one side, letting go of that, and just focusing on what's in front of us. And again, just another picture of my little dog. We were on Crosby Beach, which is just near Liverpool, and for those of you who haven't been, there's loads of these statues that are all down the beach. I forget the name of the artist, but there's loads and loads of these statues. And my dog, being a complete idiot, took her tennis ball and went and lay down next to one of these statues, waiting for said statue to throw the ball for her. I left her there for about 4 or 5 minutes before I kind of threw it herself. But I think what I really love about this example is that she wasn't embarrassed, she wasn't bothered. She'd done the most stupid thing I've ever seen her do, but she got over it, she forgot about it within seconds. And I think if that's not mindfulness, then I don't know what is. Anywho, again, I'm running out of time rapidly, so I will gloss over some of this stuff, but I just wanted to touch on the importance for me of awareness and by thinking about how we respond, we can often have some choice and control over that. So there was a fellow that I worked with who I was going to talk in more detail about, but a fellow that I worked with who basically, the key thing for him was that despite how bad he was feeling, he was still able to be friendly and polite to the nurses when they came in. He was still able to have a little bit of a laugh and a joke with them. And that was so crucial for him. That was such an important part of his values and his identity, that by noticing that and paying attention to that, it helped him to feel a bit more in control. It's like, well, even though I'm feeling awful, I'm going through this awful, awful time, I can still do this. And that was really powerful. So just noticing that, thinking about that was really helpful. Right, I'm gonna scooch forward a bit more. Yeah, I'll send these slides over. I think they're all pretty self-explanatory. Bit about normalising I've touched on. I just wanted to say a little bit about values just very quickly to finish. Again, I know other speakers have talked about this, so I'm not going to go in loads of detail, but how we define values is important. It can be really helpful in thinking about what's going on when we're disconnected from that and how it can affect our behaviour. There are various exercises and things to do to connect with our values, not always going to be appropriate in this setting. I really like the thinking about your 100th birthday party type exercise, and I use that quite a lot in more longer term therapy stuff that I do, but it's not, for obvious reasons, not really going to fit. Similarly, I really like values cards and use them quite a lot in one-to-one therapy work that I do, but again, in this context, it's not really going to work. More practically than anything, you're not going to be wanting to mess with cards at bedside. Often people are struggling to write, struggling to think. They're just not in a place often for thinking about some of that bigger stuff. And often people are at that early stage of adjustment where they can't do the things they would usually, and they might never do them again. You know, especially if somebody's got new physical impairments or new cognitive impairments, life's going to change. So I think there are adjustments, but I think these things can still be part of the conversation. And I think often I try and tune into values when I'm talking to people about what they're struggling with, what they're missing, what is it that's keeping you going and that you want to get home for. What about this is so tough for you? Why do you think you're finding this so difficult? Is it because you really struggle with being out of control? Okay, what is that about? Is that about you being independent is really important to you? Okay, how can we think about ways to tap into that? Thinking about what people are most worried about, again, that can often tap into values. I really find that these difficult periods can push people to think about what's most important to them, and often it's things like family. You know, people who have worked with a few people who have very high pressure, busy jobs, who all of this stuff has made them stop and realise what's important, and for them it was family rather than work. And it can be a real time of change and a real time of reflection if we can have those kinds of conversations carefully and thoughtfully. I just want to touch as well on, I mentioned emotional ability before. I think a lot of people with kind of these kinds of cognitive problems will have very strong emotions that just come as waves out of nowhere. So I think we can still respond to those in a values-driven way. How do you want to respond when you feel really anxious or when you feel really overwhelmed? What do you think might be useful? And then I'm just going to scooch forward a bit. I think there's also a role for speaking to families as well about some of this stuff. You know, how did Dad spend his days off? What was most important to him? If he'd have had an unexpected windfall, if he'd won the lottery, what would he have done with it? Did he ever speak about what he wanted if he got ill, or what he wanted when he was older? Essentially, how can we think about these values for somebody who might not be able to articulate them themselves, and how can we hold on to them, and how can we share them with people who need to know about them? And I just want to touch on the mental capacity stuff as well. I was going to speak a bit more on this, but I've rambled too much. I think there's a very close relationship, isn't there, between, you know, best interests and values. And I think we talk about doing decisions in people's best interests in a mental capacity context, but I think we can bring values into that conversation really nicely, especially when we're working with staff teams who might be quite anxious themselves about, for example, somebody going home, even if that's a bit of a risk. Helping somebody to see that as being linked to the values, and actually that's what's really important to them, and helping us as a system understand maybe what's driving people's decision making. I'm rapidly running out of time, so I'm just going to scooch forward. I'll tell you about Clint, another film reference. This is from the film Gran Torino, for those of you who haven't seen it. I had a really lovely conversation with a patient a couple of weeks ago. Big Clint Eastwood fan, was talking a lot about, we were just chatting really, talking about Clint Eastwood and that kind of stuff. And then he was saying basically how, because of his condition, he couldn't do any of the things that he once did, couldn't handle situations in the way that he wanted to. So we ended up chatting about this film, Gran Torino, which, again, for those of you not seen it, in a nutshell, it's basically about, you know, Clint Eastwood being Clint Eastwood, but he's getting on in life. He's an old man. He can't respond to the situations and the challenges in the way that he would usually. So he has to come up with pretty creative ways to solve problems. I'm not going to say any more about the film because you should go and watch it. It's a good film. I'm not going to talk about my case study, sorry, but I'm happy to chat to anyone one-on-one if anybody wants to. The take-home point of this was going to be about executive functioning type stuff, because these were the kind of challenges that that really came up for this chap. I'll skip forwards to what worked, what helped, and essentially it was bringing in the value stuff. It was about focusing on really concrete examples of what was important to him. So this person who struggled with his awareness, he didn't really get that there was anything different. What we ended up doing was using really practical examples of planning out functional tasks. So this person did a lot of DIY type stuff that was really important to him. We ended up sitting, getting a pen and paper and planning out a task. I think it was repairing a table or something of that ilk. But we planned that out and he found it really tough. So that became a really nice jumping off point for then, okay, well, you might really struggle with that in everyday life. How are we going to work with that? How are we going to do that? And just trying to create a bit of openness to the idea that things are different now. That doesn't mean they're awful. That doesn't mean that they're completely gone. We can still bring in some of the meaningful values in your life, but we're going to need to do that a bit differently. Right. Sorry for running over a couple of minutes. Just, I guess, to summarise for me, sorry, you know, if this has been a bit rambly, but hopefully the point I've got across is that there are lots of these ideas that I think can really fit. You know, I think for me, the main thing about ACT is that it's not about trying to get rid of difficult feelings. It's about doing what matters. It's about valued behaviour and doing the things that can help us cope with that. You know, by being able to be a bit more open to this stuff, I think we can help both the person, the patient, family members and our colleagues, even in very brief one-off conversations. And I think from my point of view, as I said right at the top of the session, I'm not a purist in this stuff. I'm not an expert by any stretch of the imagination. You know, I'm not very good at the theory side of it. And I think, like with any approach, there's a lot of jargon goes into ACT. So what I would say is just really try and immerse yourselves in it as much as you can. You know, there's lots of good accessible resources out there, loads of really nice, easy to read books, YouTube videos. I get a lot from the Facebook and Twitter conversations that go on, because I find those really helpful in just gradually helping me build my understanding of what we're actually on about. But fundamentally, I just really like this triangle. I think that really captures the key bits. Just a very quick plug, as I mentioned, we're in the process of doing a book, which is hopefully going to be out next year sometime, COVID dependent. So this will be about brain injury generally. So we've got lots of different chapters planned about various different types of brain injury in different contexts. So hopefully that'll be a nice way to bring together some of the bits and pieces that I've touched on. Right, that's about it from me. Thank you. I will take a breath.
Thank you very much, Will. That was a really interesting and informative talk. I work in the community, so much later in rehab, so it's really interesting to hear about those conversations happening earlier on. Unfortunately, I think we're completely out of time for questions. There are a couple there, Will, so I don't know if you'd be happy to answer those questions that the people have submitted privately by messaging them directly.
I'm not sure.
Because there's a couple of, and I think there's lots of fans of your dog as well in the chat section, so she's got quite a following. But thank you once again, and thank you to everyone that's attended today, and I hope everyone's enjoyed the session.
Thank you, and sorry for running over a bit. Sorry if anyone has questions that I didn't have a chance to get to. I'm very rambly, but yeah, just thank you for the opportunity, and thanks for us, and thanks to everyone involved with it.
And everyone will get your slides, so they'll have an opportunity to go through, and I can see that you've put loads of helpful resources in there, so that's really, really useful. Thanks very much, Will. Nice to meet you.
You too.